Good day and welcome to Dental XP. I'm Dr. Dwayne Caratu. For approximately the next hour, I'm going to share with you prosthetic strategies to enhance dental implant aesthetics. I bring you greetings from Vancouver, Canada, where we're enjoying a beautiful winter, and let me tell you that the skiing at Whistler is absolutely fantastic. I like to intersperse a little bit of philosophy throughout my presentations, and I have an initial thought to share with you this evening. There are two mistakes one can make along the road to knowledge. The first being not starting. The second is not going all the way. Well, certainly tonight we've started a journey, and let's finish it by going all the way. When we look at a tooth, a failing tooth, particularly in the anterior aesthetic zone, we know we must replace it with a dental implant. It's not simply a question of osseointegration, but how to master the aesthetics. Control the hard and soft tissues so that the crown represents a true illusion of nature. When we look at this radiograph, it's not the crown that's unique. It's not the apex of the implant that's unique, but rather the connection between the implant and the abutment that makes this appearance so special. The preservation of the bone, the supporting of the hard tissues, which in turn allow the soft tissues to stay in place. And when we look at the initial clinical radiographs of this patient, the failing tooth number 10, we recognize that we truly have to understand the biology of the system to be able to remove it, replace it with an endosseous implant, and the photograph on the right come up with ideal tissue contours. Now, this case is particularly important because it's a critical case for the office. It happens to be the wife of one of the foremost rock and rollers in the world. And I know this tooth, this smile, this face will be seen in Vancouver, Los Angeles, New York, London, Switzerland, wherever they may be on business and or pleasure. We understand that the periodontium between a natural tooth and a dental implant is different. We like to look at the aesthetic outcomes and suggest that it's the same situation, but definitely it's not. The gingival fiber apparatus within the connective tissue around a tooth inserts perpendicular to the cementum. That is very different to the gingival fiber apparatus surrounding an implant, which runs in a parallel fashion, leaving the implant more susceptible to bacterial invasion and the effects of the inflammatory responses. We see this smile in black and white. We notice the dentition, we notice the gingiva, the reedy pegs, the shadowing, the highlights, the framing of the teeth. It looks ideal. Of these four incisors, one of them is an implant-supported restoration. Perhaps you can tell, perhaps it's difficult. But we don't live in a black and white world. We live in a world of color, where the gingiva is pink, the teeth are a shade of white, and there's a frame of the lips all around it. And this sometimes can lead to some deceptive qualities. We call this pink and white aesthetics. And in order to achieve this, in order to maximize the pink and white aesthetics, there must be an underlying harmony between the hard and soft tissues. Everything should be made as simple as possible, but not simpler. So true. To me, simplification in the realm of dentistry is really trifold. There's science, the research and development that the companies have given us. There's art. Art can be surgical, art can be ceramics. The ability of our surgeons and our ceramic personnel is so critical. Their abilities, the human factor. And lastly, the management. The management of the clinical situation and the management of the patient, recognizing that the patient is who we are doing the work for. And yes, they too are an integral part of the team. we must look at the dental-alveolar complex and implants and how they relate. We have this diagram, this cartoon of an implant in alveolar bone surrounded by gingiva with an abutment and a crown. So often we focus on the crown coming out of the gingiva, what I like to term the emergence profile. But really, that is not where the aesthetics are created. That is not where the aesthetics are maintained. It comes from a deeper level where the abutment and the implant interact. What Salam and Garber have called the submergence profile. This is the evolution of aesthetics. My good friend Barry Goldenberg, who is speaking next week at the Dental XP seminar in Las Vegas, has his ACT principle. A plus C equals T. Yes, I simplify it somewhat. The abutment plus the crown equals tissue shape. I modify this slightly. I like to say A plus B plus C equals T. The abutment plus the bone plus the crown equals the tissue shape. For it's the bone that supports the tissue. It's the bone that is sculpted by the abutment. And also the crown has an integral role in the tissue shape. So if we look at these artist renderings of the connective tissue apparatus around a tooth, compare that to an implant, we can see how they're similar yet different. We focus on the areas of importance, the perpendicular versus parallel fiber apparatus. And once we enlarge them and take a close look, if I have to replace a natural tooth with an endosseous implant, I want to mimic what I can find in nature as best I can with my implant choice, with my abutment connection, and with my final restoration. So let's walk through some simple strategies to develop aesthetics. The first point, using the sulcus former to develop the soft tissues. The sulcus former being another word for a transitional abutment or a healing abutment. If we look at an implant that's been placed into a dry skull and a sulcus former on it, we'll notice a few things immediately. We don't have any soft tissue here to get in the way, so we can concentrate on the interactions that are at play here. First of all, they tend to be too large. Remember, these are stock components. They tend to be too large for your individual area. So what will happen is they can block out the papilla in the interproximal zone, both on the mesial and the distal aspects. Secondly, if we look at the facial profile, again, the stock component tends to be too large. If an abutment is too prominent facially, we know that it will push the soft tissues apically. Another aesthetic problem. And they are perfectly round. Why is that an issue? Because I have never seen a round tooth. In my office, I like to customize these when I can. I will take the abutment that I've chosen to use, the sulcus former, the healing abutment. I will place it in an implant analog chairside, and I have a laboratory holder to hold that. And with a simple carbide burr and polishing wheels, I will fashion the root anatomy of the tooth I'm replacing. So if I'm replacing an incisor, whether it's central or lateral, I will make it roughly triangular shape. A canine will be oval, and a bicuspid will be elliptical. Very, very simple. Takes only minutes to do, but has a tremendous effect on the aesthetics. What happens? The facial profile is flatter, allows the tissue to fall down. I would much rather have too much facial tissue than not enough. And look interproximally. We've opened up the interproximal embrasures. We're going to create papilla. Now, this technique can only work if you have a two-piece sulcus former or healing abutment, so that after you've created it, after you've sculpted it, after you've polished it, you can position it with a hemostat in the ideal positioning, and then with your other hand, set the screw. Clinically, this is what it looks like. We can have situations where we've maintained papilla. Unfortunately, because of the nature of my referral practice, I can't always touch the adjacent crowns as well I would like to. But I want to provide the best implant crown that I can. Looking at the tissues, supporting the buccal soft tissue, maintaining the papilla. Following with another case. Again, the contour is so important. Here we have a tooth that is fractured. The patient already has dental implants in the area surrounding it. We're going to atraumatically remove the tooth with a Bennett's extractor, place our platform switch ankylosing implant, put on a customized sulcus former, all at the initial stage. This is immediate implant placement. We're going to wait the requisite healing time, take our closed tray impression, and fabricate an Atlantis customized titanium abutment. Torque the prosthetic screw to 15 Newton centimeters and lute the final crown with Implant. The two central incisors are implant supported crowns, done at different eras with the same implant. The implant crown on tooth number 8 is an Atlantis abutment. The implant crown on tooth number 9 is a stock balance anterior abutment. Individually, they both look good, but side by side, the Atlantis abutment, I think, does look better. The second technique which we have available to us, lab-assisted smile building. This is the same concept as the first step, but rather than creating the sulcus former or healing abutment chairside, we have a laboratory partner create it for us. The advantage being it can be made in pink acrylic. So here we have failing tooth number 9. It's going to be removed, an implant placed, and with a quick impression, we have the laboratory make this for us. It is indexed, so we know which side points to the buccal. And again, it mimics the cross-sectional anatomy of the tooth, which is taken from the impression at the time of tooth extraction and implant placement. So that's going to maintain our soft tissues for us through the healing phase. So when we look at the final implant-supported crown on the right-hand screen is tooth number 9. We have absolutely ideal aesthetics, maintenance of the soft tissue, and harmony of the hard and soft tissues. And we have our photo montage on the left, overlaid a radiograph of the final case with the clinical photograph, and then a greatly enhanced photograph, magnified several times to look at the marginal integrity. Our third step, we can utilize a provisional restoration to alter the gingival profile. This is perhaps the single most powerful technique we have available to us. Using the provisional to create the ideal aesthetics. And when we have a rectangular shaped tooth, it can be especially beneficial to our final outcome. We're looking at a series of anterior teeth here. They are failing. Tooth number 8 is hopeless. I would suggest that there's a horizontal fracture at the apex of the cast post and core, as well as resorption of the apex of the tooth. The tooth is going to come out. The ankylosing implant is going to be placed. At the time of placement, a sulcus former is put on. This is prior to my shaping the sulcus formers, so you see it unaltered. And now we've come time to put on provisional restorations on all the teeth. We have all 4 anterior teeth prepared, and we on the tooth number implant on in position tooth number 8, there is a titanium balanced anterior abutment. Here's our first set of provisionals. I agree. The aesthetics is not great. We have too much tissue. That's a good thing. We're going to alter the profile of this crown to push the tissue apically and create an ideal contour. By adding acrylic, changing the cervical bulge, altering the submergence profile, we are pushing the tissue zenith. At the same time, we're sculpting the abutment, we're changing the contours of the provisional restoration, and by doing that, we're changing the contours of the soft tissues. And now we have our final set of provisional restorations, and we're able to proceed to the definitive restoration. We have sculpted the peri-implant soft tissues with prosthetic manipulation. This is in a thick, flat periodontium with rectangular teeth. John Coyce, in 2001, talked about peri-implant aesthetics and what are the 5 diagnostic keys. He listed each of the 5 keys, but more importantly, he put each of the keys and then compared it to what he thought was low risk compared to what he thought was high risk. Low risk is going to be green, high risk is going to be red. So the first key, tooth position, free gingival margin. The more coronal the free gingival margin is, or the more lingual the tooth position is, the better. Conversely, the more apical the free gingival margin, or the more buccal the tooth position is, the more dangerous of a situation for final aesthetics that is. If you look at gingival form, a flat scallop is beneficial, a high scallop is dangerous. The biotype, thick is good, thin is bad. The tooth shape, a rectangular tooth versus a triangular tooth. Osseous crest position, high crest versus low crest. When you put these 5 points together, you can derive an outcome expectation. The more greens you have, the higher the probability for a good aesthetic outcome. The more reds you have, the tougher the case aesthetically will be. Use that. Understand it. It's a powerful tool, part of your aesthetic flowchart. Make sure your patient understands what the potential for final aesthetics can be. Under-promise and over-deliver are very, very important points. When comparing the rectangular versus triangular tooth, there are some very, very important differences. They cannot be restored with the same implant position. Triangular teeth need an implant to be placed slightly deeper. Triangular teeth have more open interproximal spaces, so you need that room, that vertical height, that submergence profile to create the contour of the final restoration so that the interproximal spaces can be adequately filled as the demands dictated by the tooth shape and the gingival biotype. Anatomically correct positioning of the provisional restoration, of the contours of the provisional, evoke blanching and relocate the soft tissue. And as with anything in restorative dentistry, impression technique is very, very important. Here we have a clinical situation of a tooth number 8 has been replaced by an endosseous implant. The patient is a young lady in her late 20s. She lost her tooth. The implant was placed in Singapore. And there was no communication between the surgical doctor in Singapore and the restorative doctor, which was myself, at the time of treatment planning. I may not have elected for this implant to be placed. I may not have elected it for it to be placed in this position. And I may not have elected for this butt joint type implant to be placed subcrestally. But it ends up in my office, and as a restorative dentist, I'm asked to create a restoration on this and to create aesthetics for this young patient. And to make matters worse, there was minimal communication between the surgeon and myself when the patient was in my office for the final restoration. It is a thin, scalloped biotype. And here we are, we've taken an initial impression, we create a provisional restoration, our first attempt, and we know it's not ideal. There is too much tissue, but too much tissue is a good thing. We're going to take our time and mark the gingival positioning. We're going to remove the provisional restoration, and we're going to add to the cervical bulge. We're going to shape the submergence profile. This is acrylic. We can simply add acrylic, change the contour, insert the provisional restoration, see the patient in a week, repeat as necessary. We notice that when we put in the provisional restoration, we have immediate tissue blanching. This is what we want to see. And as we follow it through time, we see the arcuate form, the gingival zenith where we want it to be, and the gingival profile between tooth number 8 and tooth number 9 are starting to reflect each other. Once we're satisfied with our gingival profile, now we can turn our attention to the impression technique, or as I like to call, capturing reality. We must use an open impression tray for this procedure. And we do know that in the time it takes to remove the provisional restoration and to place the impression coping, the sulcular tissues will slump. We need to create a hard form, a matrix, a scaffold that will prevent any change in sulcular tissues. I like to inject flowable composite scaffold, which will prevent the changes in these tissue profiles. Creating a simple, quick, open impression tray from what we have at hand in the office. We've made mechanical retention grooves in this impression post for the flowable composite. We take the provisional restoration off, we put the impression coping on, we flow composite in the sulcus. All of this should take no more than 20 seconds. It's light cured. Then by simply adding on the extension, we've created a very quick chairside open impression tray. Take our polyvinyl siloxane impression, let it set, remove, and place the implant analog in the impression with the composite reproduction of the sulcular area. Our lab then has the task of creating a new reality. An Atlantis zirconium abutment for this implant, a zirconium crown, are fabricated and are inserted. Photographs at the time of insertion show the tissue form, and when we follow it through a year, we see maintenance of that ideal architecture. This roll of the tissue on the implant on tooth position number 8 is comparable to the roll of the tissue on the tooth in position number 9. This would never have been achieved with a scalpel blade or a laser, only by pushing the tissue apically with a provisional restoration can this be achieved. Umberto Eco said, "Beauty is difficult to describe, but when you will recognize it when you come across it." My fourth point, immediate loading. Non-functionally loaded provisional restorations. It's very important to recognize the non-functional part of that statement. There is a biological sequelae of removing teeth. It's very well documented that when you remove a tooth, especially in the anterior aesthetic area, the unsupported alveolus will resorb. It'll resorb buccolingually and it'll resorb coronal apically. Siebert had a very, very good classification system for this. Even in Rosenberg wrote that the collapse of the buccal plate, 75% loss of total volume if nothing is done, 23% loss of volume if immediate bone replacement, such as a graft, is completed. I like to utilize, where possible, the patient's existing crown for an immediate provisional restoration. We have a clinical situation here where tooth number 9 is failing. Inadequate ferrule on the crown has caused blackening of the root, and the post and core to come uncemented several times. The tooth is hopeless. We're going to remove it, replace it with an end-osseous implant, and use her existing crown as the immediate provisional restoration. So let's follow through the case. We're using the Meisinger-Bennis extractor to remove the root in an atraumatic fashion. The root comes out whole as a tensile force is applied on the root, severing the periodontal ligament, and no fracturing of the buccal plate of bone. We go through our typical osteotomy sequencing. Our platform switched ankylosing implant is positioned subcrustally, and in this case, a stock titanium balanced anterior abutment is placed, and with the photograph on the right, we see a week after surgery what her provisional crown looked like. This is the crown that she came in with on the day of surgery. It was removed and positioned on the implant. Now when it comes time for her final aesthetic case, we position the definitive abutment related to the new crown and veneer preparations using a jig and the day of insertion. And we can follow this case to 1 year, very little change in the soft tissue profile. And now we've seen this case for 6 years follow-up. We look at the 6-year radiograph, and what do we notice? We notice that the bone has grown over the shoulder. The implant has become laterally positioned relative to the abutment. There's a very, very small gap between the abutment and the bone. And the bone is supporting the interproximal soft tissues, and hence we have papilla in these areas. We had the luxury of taking a CBCT 6 years after the initial surgery. The patient was having implants in another part of the mouth, and as a result, we could come back and retrospectively analyze the buccal plate of bone around this implant in position number 9. And we look at the maintenance radiographically of the buccal plate. And this is further conclusive evidence of the success, both functionally and aesthetically, of this type of treatment. So you may ask yourself a question: how do I do an immediate non-functional loaded provisional restoration? Well, let's go through a few quick steps. Again, we're going to turn to our dry skull. We're going to look at tooth number 9. Tooth number 9 is going to be removed and replaced with an end-osseous implant. But prior to removal of the tooth, we make an incisal edge index with GC pattern resin. Make a doughy rectangle, or cube rather. Place it on the incisal edges. Get a good impression of the incisal edge, but make sure we don't get it into any undercuts. Once it has set, you can remove it and you can trim it. All you're interested in is the index of the incisal edge positions. Then, with periotomes or Bennex extractor, whatever tool you prefer, you can atraumatically remove the tooth, leaving an intact socket environment. Of course, you're going to check for any fenestrations or dehiscences of the buccal plate of bone. Once the tooth is removed, cut the root off and hollow out the crown. If it's a prosthetic crown, you can follow the contours of the ceramics. If it's an anatomical crown, you can hollow out the dentin, leaving an enamel shell. Then proceed with your osteotomy sequences, as per usual. Once you've created the osteotomy, hugging the palatal bone, leaving a gap towards the buccal so we don't impinge on that buccal plate. We can take our implant, place our implant in the area, secure it, remove the transfer mounts. In this case now we're positioning a definitive balance and anterior abutment, titanium abutment. On SEM, this particular abutment implant interface looks like this, a conical cone connection, demonstrating a platform shift in the implant and a long Morris taper. The prosthetic screw is set at 15 Newton centimeters. Our hollowed out crown is then checked on the abutment for pacificity of fit, and the incisal edge index is put back on, making sure that all components can seat passively. If there happens to be a perforation in the buccal or lingual aspect, it's not a problem. Then lute the interior aspect with a cold cure acrylic. I'm using salt and pepper technique and a sable hair paintbrush. Putting it back on the abutment in the patient's mouth, placing the incisal edge index back in place. I am not looking to overfill this. I'm not looking to get perfect margins at this point. Rather, I'm looking simply to relate the incisal edge index to the crown and the crown to the abutment. If those three components all line up, the rest will be easy. I then go to my bench top. I put a corresponding abutment on an analog in my lab holder. I now finish the margins outside the mouth. Again, salt and pepper technique, sable hair paintbrush, paint it on, let it set, trim, and polish my margins. So when I'm finally done, the photograph on right of the implant in position, tooth number 9, is what I have. I have ample room for the soft tissue to fill that area and maintain the aesthetics. That case was demonstrated with definitive titanium abutments. We also have available to us provisional abutments, PEEK, which is a resin, zirconium oxide abutments. Considerably less expensive. You can change it, alter it, do what you want with it without the worry of the financial overhead. Here we have a tooth number 7 that has obviously failed, endodontically treated tooth, a crown has fractured. We're going to replace it with an endosseous implant in an immediate provisionalization. Take our requisite CBCT scan, do our in-office digital surgery. Interesting to note that David Hatcher and Curley wrote a paper in the Journal of the California Dental Association 2009 stating that CBCT now fulfills the requirements to be considered a standard of care in the diagnosis and planning of implant treatment. It's a very powerful statement. I strongly encourage all the participants of Dental XP to utilize the CBC technology that we have available to us for the diagnosis, for the treatment planning, and perhaps even CAD/CAM treatment planning of all our implant patients. The British Dental Journal published recently that there was a 26% reduction in surgical time with the use of CBCT. And of course, I think it goes without saying, if we utilize CBCT for our diagnosis and treatment planning, the images must be read by an oral maxillofacial radiologist to screen for any potential pathology. In the medical profession, that goes without saying. In the dental profession, it is still a lesson we are slow to learn and slow to take. So here we are back to the case. Tooth number 7 has failed. We remove the clinical crown in the fashion we've described previously with a GC pattern resin incisal edge index. Atraumatically remove the root. Place a platform shift implant. Subcrestal positioning. And now we have the beige abutment, peak zirconium oxide. We prep it slightly in the mouth. It cuts like resin. And we take the patient's crown using the incisal edge index, reline it on the abutment, finish it outside the mouth, and cement it in place. Very careful to remove any excess cement. If you wish to have a screw retained provisional restoration, this is also possible. When it comes time for the final restoration, this is our definitive radiograph showing again the bone over the shoulder of the implant following the contour of the abutment, and the final clinical photograph. When we enlarge the radiograph, pay attention to the bony topography around the implant and around the abutment. This clearly demonstrates why it is important to have a system not only that enhances the biological situation, but maintains it through the life of the implant and restoration. And our photo montage showing ideal hard tissue contours, ideal soft tissue contours, and partnerships with our artists, the surgeon, the ceramist, and of course the patient. I like to call this minimal abutment change, or the MAC technique. Abramson said there was an average of 5 abutment changes in normal implant cases, and that can lead to a loss of bone. In the case that I just demonstrated, there were only 3 abutment changes. This, along with the conical cone connection, maximizes the peri-implant bone stability. And technique number 5, our last technique that we're going to discuss today. This is venturing into the 4th dimension. And the 4th dimension is not as simple as 1, 2, or 3. We're quite comfortable living in 3-dimensional world. We look at 2-dimensional photographs. But now implant dentistry is going into the 4th dimension. My good friend Scott Gans says problems occur when we apply 2-dimensional concepts in a 3-dimensional reality. Now we're planning in 4 dimensions. What is the 4th dimension? Of course, 4th dimension relates to time, or the space-timing continuum, as I like to call it. And timing relates to where, in 360 degrees of rotation, the implant finds itself at the final ideal position. Now imagine you're placing the implant within the osteotomy and the implant is rotating. Every complete rotation is 360 degrees as it's moving apically. So when that implant comes to its final terminal position, where in 360 degrees is it going to end up? We can predict and we can pre-plan for this. We do have the power to do that. William Pollard said to change is difficult. Not to change is fatal. And I think this is one of the great changes that's coming in implant dentistry. I like to call this tomorrow's surgery today the CAD/CAM advantage. This idea was first thought up a few years ago and demonstrated live at the Pacific Dental Conference in 2011 in front of 300 attendees. Of course, to consider anything in the realm of CAD/CAM dentistry, one has to empower digital technology, the power of the computer, the ability of the zeros and ones of the digital sequence. We have a gentleman here who has lost the clinical crown on tooth number 7. We maintained the root in its position so that we can go through the treatment planning and setup for this case. We have here the CBCT. That's going to be the basis of our digital treatment planning sequencing. Looking at the tooth in coronal sections, looking at the area in sagittal sections, we see we do have good bone. We do have adequate height, width, buccolingual dimension. We're going to plan on removing the root, placing an implant, but we're going to do it one step further. We're going to put a customized abutment on the implant at the time of surgery, never to remove it. And we have a prefabricated provisional restoration. Of course, this being the first time this procedure was done, we did have backup protocol available. Another section from the same CBCT in the planning software. And now we're looking at materialized software. We're creating this in Simplant, the implant replica, the digital wax-up of the abutment, and the digital wax-up of the new replacement tooth. Because the patient presented without a clinical crown in tooth number 7, we did a mirror digital image of tooth number 10. Place it there, put our implant where we wanted the implant, and simply connected the two with our customized abutment, which is shown in blue. That tends to be what some people refer to as gymnastics, prosthetic gymnastics. But in this case, it's very predictable and very easy. On the right, we have an edited video of the actual surgery. On left, we have a video sequence of the treatment planning. And we'll go between the two. On the right, we're removing the tooth atraumatically with a Meisinger-Benix extractor, creating the channel. On the left hand of the split screen, we're showing the treatment planning, the digital wax-up, the proposed occlusion, having an underlay of the CBCT data so we can analyze the hard tissue before the surgery. We've connected the Meisinger-Benix extractor. We're going to remove the tooth now, atraumatically. And the tooth comes out without fracturing any buccal plate of bone. Of course, we check the socket environment with our perioprobe for any dehiscences or fenestrations. And now we position the customized surgical guide. Put our first ring sleeve in. This is going to guide our drills. Changing rig guides for larger drills sequencing. Working through the CAD/CAM guide. Placing the implant. This particular case, we happen to use a hand ratchet. Checking the positioning. Verifying the position. Is it where we planned it to be? Is it what we want? Subcrestal implant placement. Now we're going to turn the implant the final few quarter turns to get the markers aligned so we have our final 360-degree positioning, and also our resistance torque. We're satisfied, and now it comes time to take the prefabricated zirconium abutment, secure it in place using a jig. It is indexed, but we still used a jig to make sure it was fully seated. Our provisional restoration, filling the screw access hole once we've torqued the screw to 15 Newton centimeters. And cementing with a provisional type cement. This procedure from start to finish took no more than 28 minutes, and the patient was dismissed. Came back to our office at 3 months, and at 5 months we changed the provisional restoration to a definitive zirconium restoration, never removing the final abutment. These are stereolithic models that were created for the surgery, showing the osteotomy and the position of the implant. And we can reflect back on this case and determine what were the building blocks of success. Well, atraumatic extraction of tooth number 7, what we might call here tooth number 12. Immediate implant placement with a surgical guide. Prefabricated customized zirconium abutment. Immediate non-functional provisional restoration. And definitive restoration placed at somewhere between 4 and 5 months. These points put together take us from left to right, from a hopeless tooth number 7 through to the CAD/CAM design to the final abutment and crown. And when we look at the radiographs and we enlarge it, we can again see the ideal topography of bone relative to the implant or relative to the abutment. This shows me clinical evidence of what Henry Salama and Paul Viegel talk about: one abutment, one time. There are 3 points of success here. One is the implant is stabilization within bone. Secondly, the platform switch and the bone going over the shoulder of the implant, and the extremely close proximity radiographically of the bone to the implant. And thirdly, the zirconium, the bone following the zirconium and supporting the overlying soft tissue. I call this protocol the zero abutment change, or ZAC protocol, which is also called one abutment, one time. It maximizes the potential to maintain all the peri-implant bone and soft tissue by never causing a disturbance to it. My clinical radiograph on the left is clinically evident success. When I compare it to the histology of Dietmar Wang in Germany, the same implant in the canine model, and he has evidence-based success, the two are comparable. Bone forming on the abutment means the abutment does not move. Very important concept. And again, the final photo montage in this case of the underlying treatment plan in materialized implant with the clinical photograph over top, following it through, and the final case. I show this final photograph, and I do show the slight loss of papilla distal to tooth number 7. Now that is to be expected, because if we look at the image on the left of the pre-treatment CBCT, we'll notice there's no bone in that area. And if there's no bone, there's going to be no papilla. So that is not a failure of treatment, but rather a sequelae of anatomy. And if we look at the guidelines of the Academy of Osseointegration for provision of dental implants and associated patient care, there's a statement of outcomes assessment. The desired outcome of successful implant therapy is not only the achievement of a therapeutic goal, but the maintenance of a stable, functional, and aesthetically acceptable tooth replacement for the patient. I think we've achieved that in the cases we've shown. And I want to finalize with one case that's very dear to me. This happens to be the hygienist of a friend of mine, and she fractured her maxillary right lateral incisor. This is tooth number 7. When we talked about pink and white aesthetics at the beginning of today's webinar, this is the case that we showed. The tooth was removed using all the techniques we've shared previously: GC pattern resin index, atraumatic tooth extraction, implant placement, relining of the clinical crown on the abutment, and then finalizing the case at insertion and then through time. We've maximized the pink aesthetics, we've maximized the white aesthetics. We have 4 beautiful incisors, and when we look at this now critically in black and white, the reedy pigs become apparent to us. The highlights, the contours, the contrasts are very apparent, and it's very difficult to discern what is real and what is illusion. In 2013, is osseointegration predictable? It definitely is. Are aesthetics predictable? No, they're not. Is there a formula for aesthetic reconstruction? We as clinicians are continually searching for guidelines. And a lot of what we do is controlled trial and error. A lot of people like to say dentistry by design. I like to think of it not by chance. I want to give a special thank you to the artist ceramists who created the restorations which have been shown. Marco Biskitsa, Master Dental Technician now in Seattle. Yang Kim, RDT in Vancouver. Henry Heinz, Master Dental Technician in Halifax. And Renzo Castellini, Master Dental Technician in Los Angeles. I want to thank everybody at Dental XP for a wonderful webinar. We've shared an hour of your time, and I appreciate it. Thank you, and have a good day.